Good afternoon and welcome to the Rural Communities Opioid Response Program for East Tennessee Consortium Policy Forum. My name is Brian Wimbigler. I'm an assistant professor for UT's College of Pharmacy and will be one of your facilitators for today's activities. I am joined this afternoon by my co-facilitator, Dr. Carol Myers, with UT's College of Nursing, who will be moderating the upcoming panel discussion. Today's programming is funded through a HRSA grant and brought to you by the team at Project Hope, Healing Opioid Use Disorder Through Prevention and Expertise, led by Dr. Lori Meschke with UT's Department of Public Health and Dr. Jennifer Torville with UT's College of Nursing, with overall project management support from postdoctoral research assistant Jude Zhang. Before we begin, let me take a moment to review the Zoom setup for the forum. Upon entry, everyone's microphones are automatically muted. Our team will be monitoring the chat box throughout today's activities, so please feel free to post questions and comments there. We will also utilize the chat box to post forum-related links and documents, including a telehealth brief developed by the Substance Misuse and Addiction Resource for Tennessee Policy Network. And we'll post a link to a survey for each participant to complete at the conclusion of the forum. Although unexpected, should we experience technical difficulties with Zoom performance, we may ask participants to disable their videos. Thanks to each of you for joining us. Let's get started. Today we have the distinct pleasure of being joined by Representative Robin Smith. Robin currently serves as the representative for Tennessee House District 26, representing parts of Chattanooga and Hamilton County. She has risen quickly among her House colleagues to lead as the first chairman of the Subcommittee on Life and Health Insurance, and then become chairman of the full House Insurance Committee. Legislation she sponsored and supported has included the Tennessee Right to Shop Act, providing pricing transparency for patients, the proposal to permit telemedicine for existing Tennessee healthcare clinicians with established patients to increase access and outcomes, as well as the proposals to stop the fail first approach to prescription drug access used by insurance companies in patients with advanced cancer, and a bill that ensures patients' out-of-pocket costs for prescription medications reflect the pharmaceutical manufacturer's rebate and not the list or highest price for those drugs. Robin's devotion to patients comes from her education, training and practice as a nurse, and her childhood fight with asthma. Robin graduated from the University of Tennessee, Knoxville College of Nursing, and immediately began work at the renowned Cardiac Medicine and Transplant Program at the University of Alabama Birmingham Hospital, where she worked with critically ill patients, participated in clinical research trials, and worked as part of a health team that ushered transplant patients to surgery. Robin's education continued as a graduate of Stanford University's Center for Professional Development Advanced Project Management, which has been part of her consulting and project management firm, River's Edge Alliance, founded in 2005. Her portfolio of professional services includes professional and technical writing, strategic planning, and business development, as well as government affairs and policy analysis. Robin lives in Hickson, Tennessee with her husband of almost 34 years, Scott. Their grown children, Callie, lives in Nashville, and Caleb in Johnson City. Both are pursuing their own successful careers. Robin will be part of our upcoming panel discussion. But before we get to that, we are delighted to have Dr. Stephen Loyd with us today as our keynote speaker. He is familiar to those working in the field of opioid use disorders and a true champion of and advocate for those struggling with substance use disorders. Dr. Loyd currently serves as the Chief Medical Officer of Cedar Recovery. That's an addiction treatment company headquartered in Mount Juliet, Tennessee, serving patients across Middle Tennessee. On top of his work for Cedar, he is currently a member of the Tennessee Board of Medical Examiners, as well as serving as a federal expert witness. A nationally recognized thought leader and clinician, Dr. Loyd has decades of experience in internal medicine, mental health, and substance abuse services. His backgrounds include serving as the medical director and assistant commissioner for substance abuse services with the Tennessee Department of Mental Health and Substance Abuse. Dr. Loyd has been in recovery himself since 2004. Experience addiction firsthand has allowed him to develop a unique approach to patient care that is passionate, effective, and impactful. His daily goal is to help as many people receive quality treatment they deserve in order for them to feel better, get better, and stay better. With that, I'll turn it over to Dr. Stephen Loyd.
I went into this with a little bit of an idea that I knew kind of a little bit about what I was doing, which was a joke, because I was used to treating patients that we treat in our OBOTs, that we treat with opioid use disorder using the drug Suboxone, with behavioral health components, with peer counseling, with access to the social determinants of health, stable living environment, trying to wipe out our patients who are homeless. So that's the background I brought to the OTP in Newport, and boy, was I wrong. I had really no idea what I was walking into. So I'm an optimistic guy by nature, but I'm a little bit down this morning because of just that, because some of the things that we've opened up for our patients in OBOTs through the great work of our state legislature, through the work of our legislators and leaders nationally, with relaxing requirements around telehealth, we have not opened up for patients in OTPs. We have not extended them that same level of access to care. And I can tell you that we're losing patients, we're losing Tennesseans daily because of that. And my plea is to relook at this so that we can help these folks who are marginalized and who are now even more desperate than they were before, because I am not a COVID denier. I'll also give you one other little tidbit of information. I received my second COVID vaccine Wednesday at our wonderful health department in Cocke County, and I love those folks. And afterwards, I became very sick. I've been really sick for 24 hours. I started getting better at 36 hours, and I'm still feeling a little squirrely right now, but I think I'm operational. So I do have that as a background as well, but I don't want to leave out those folks, because we need to take a look at that. So what I'm going to talk about today is really what we went through in our practices here in Middle Tennessee around transitioning to telemedicine. And it really all started about this time last year. We got through the holidays. We had heard on the news this virus, this respiratory virus that sounded to me a whole lot like SARS that I'd heard of in the past. And we were getting mixed messages from leadership within the CDC, within the federal government at the time, as to the seriousness of what this virus was like, and what it was going to be like when it hit the shores of the United States. And I'm talking as a citizen as well as an internist and a practicing physician. And so, I was curious, but to be honest with you, I wasn't really worried a whole lot. I'd have people stop me at the gym and ask me, "Hey, Steve, do we need to be worried about this thing coming up?" And my answer was, no, not really. We were able to contain the last few, mainly SARS, with some measures before it actually hit the shores of the United States, and really contain it. So I'm not that worried. And boy, I didn't give very good advice then in hindsight. And then as we started to transition into the middle of January, late January, early February, things were more serious. I was actually in Washington, D.C. at the National Prayer Breakfast the first part of February, and started to hear a lot more about the seriousness of it. I started to pay attention to what was going on, mainly out of China. And looking at the seriousness of what was really sweeping China at the time and coming to shores of the United States. And I got concerned. And so I met with our group here at work, and we had talked about telemedicine for a long time, but the only way that I could see to meet our population where they were is we had to be ready to hit the ground running with telehealth if things were going to be shut down. And so we started preparing for it then. Luckily, I've got a bunch of young folks that work for me that don't have bald heads, don't have gray hair, and don't wear glasses. And they were incredible. They went to work very, very hard and putting together platforms that we could access all the things we do. And I'm going to show you what we ran into. And boy, we were learning on the run really, really fast. And with apologies to Representative Smith, I am so sorry, but we really didn't wait on you guys. I had decided early on that I was going to ask for forgiveness rather than permission, and that I was willing to stand in front of a jury of my peers and do what we needed to do to meet our patient population, because I know from daily experience how risky their lives were. So when we shut things down, and I'm not arguing that we did the wrong things, I'm not a COVID denier, none of that stuff, but when you shut things down and you take people out of jobs that they were barely hanging on to in the first place in service industry, you really got to be careful. And I'm not saying it was the wrong thing to do, but I'm saying that we have to make sure that we've got a safety net to help these folks, because the experiences I'm going to share with you guys today are experiences I had ongoing. I didn't get any training on this. I didn't go to a course. We just decided we were going to meet people where they were, no matter what, in the best ways that we could. So this is what we came up with, literally over some long weekend nights. And those of you who know me, and Rob and Carol and my folks that I've known for a while, my technology capabilities are limited, to say the least. I'm better than Judge Sloan. I can put a picture on a PowerPoint slide, but outside of that, I'm pretty iffy. So now you're telling me that a guy whose strong suit is personal relationships and interconnections with patients in rooms, face to face, you're going to take all that away from me, and you're going to put me in front of a computer screen, and I'm somehow going to see my patients. I'm going to connect them with therapy. I'm going to continue drug screening, and drug screening is not a gotcha. It's to help people on their path to recovery. How in the world are we going to do all that? And how in the world are we going to do it over a weekend? Because Monday morning, we're going to have to do this. So what happened was things got really, really serious. I'm a huge sports fan. Maybe I need to apologize for some folks for it, but I am. And the NCAA basketball tournament was coming up. I'd just gotten back from Asheville, North Carolina, watching my beloved East Tennessee State Buccaneers qualify for the NCAA basketball tournament. And I'm already starting to talk trash because I know we're going to knock off a couple of big time programs. So I'm jacked up. And I heard that Mike DeWine, the governor of Ohio, said that we're not going to have fans at the games in Ohio. And I couldn't believe it. And then just a few days later, he came out and says, we're not only not going to have fans, we're not going to have the tournament in the state of Ohio. And then I knew things were getting serious. And then I was watching TV at the start of the week of the NCAA tournament before they announced the brackets, and they canceled the NCAA basketball tournament. I looked at my wife and I said, Karen, this is really serious, and we got to be ready to go. And we took things into high gear that weekend. And my Monday morning, we rolled out what I'm getting ready to show you. So literally over the course of a weekend, we had to pivot to a virtual patient management platform. And guys, I'm the youngest doc in our practice. Look at me. I don't have a hair on my head. Okay. And our other docs are even older than me. They can barely use their cell phone. And now I had a patient population that all had smartphones, but no experience with some of the platforms that we were talking about. So right off the bat, we were saying, oh my gosh, we have huge issues with tools. What are the tools that we need? So we needed hardware, right? We needed computers. We needed laptops. We needed tablet computers. We needed handheld smartphones. What are the software? What's the software out there available? And there is so much. If you're going out for the first time and you're worried about HIPAA compliance, and you're worried about all the DEA regulations from the federal side, and you're worried about the state regulations and what you can do in telemedicine, really it was almost overwhelming. But luckily for us, early on, we stumbled upon a Zoom platform that was HIPAA compliant. What about portals? What about apps? And you know, as I learned about this, I learned, hey, there's this thing out there called Zoom that you've actually been using for a while, that there's a version of it that you have to pay for that's HIPAA compliant. Now I started to breathe a little bit because I could operate Zoom a little bit, and I felt like I could teach my peers how to do it. And, you know, how do you do that and stay separated? So we came up with the idea of short instructional videos. So we jumped in a production room that we had actually been using to do education videos for our patients for some time. And we started utilizing those rooms to put together videos around hardware, software, how to access it for our providers who are going to be delivering telehealth services to our patients. So even really in that first day, I started to breathe a little bit easier because even I could understand how to use some of these things. Then looking at the next set of challenges, it was around internet access. Now I'm in Middle Tennessee right now. I'm in Wilson County, which is a suburb of Nashville. And we serve patients from metropolitan Davidson County. We are a TennCare practice. So let me tell you just a little bit about our practice. This is not our OBOT. This is not my methadone clinic up in Newport, Tennessee. These are outpatient clinics right here in Middle Tennessee. So we have one clinic in Mount Juliet. We have another clinic in Lebanon, which is within Wilson County, one county to the east of Davidson County. And then we have one down in Maury County, which is Columbia, Tennessee, which is south of Nashville by about an hour. And so we are spread out, to say the least. So So we are a TennCare provider. We are credentialed with all 3 MCOs. About 92% of our patients are TennCare patients. So as you all know, TennCare provides their services through 3 MCOs: United Healthcare, Blue Cross Blue Shield, which is Blue Care, and then Amerigroup. So we are a provider for that. We are also a provider for the state of Tennessee using TechBot money, which is grants for people to access medication-assisted treatment services that do not otherwise qualify for state Medicaid services. So we are also a TechBot provider. That expired January 1st, but I think we were the largest TechBot provider in the state. We had over 140 patients enrolled. So that's about 97% of our practice. We are not a cash clinic. And then the other part of our practice is made up of private insurance, which ironically, a lot of them were actually our only cash patients because their private insurance did not offer the level of benefits that our state Medicaid agency offered. And so we're working really hard to change that. So that's just to give you an idea about what our clinic makeup is, and some of the challenges that we face with that as the background. So right off the bat, internet access. So Davidson County is one thing, Wilson County is one thing. We have pretty good internet service here, all right? But we service counties all around because we are a TennCare provider, and a lot of those places don't have TennCare providers in their area. All they had were cash clinics. And so they're going to drive a certain distance to see us. Now let's talk about that for a little bit, because I want to throw in some absolute wonderful jewel nuggets about telemedicine that we discovered. So, and I'm not knocking the goodness. I believe in the goodness of people. I believe that we will overcome. I believe that. Okay. But there are some people out there who are pretty mean sometimes too. So a lot of folks will pay lip service to wanting to help people with opioid use disorder or help substance use disorder. And they really want to help them, but they don't want you to do it in their backyard. But fine, Steve, we would like you to do this, but we would like you to go over here to this part of town where nobody can see you. And I get that all the time because I want to treat addiction medicine patients right next to the cardiologist, right next to the pulmonologist, because we are mainstream medicine. We're not dealing with a moral failure. We're dealing with a treatable medical condition. So one of the things that we saw right off the bat was we had a tremendous decrease in complaints from our neighbors. Right? Our patients don't look like theirs sometimes. And sometimes they drive cars that look a little bit different than everybody else's car. Right? And so now our patients are suddenly showing up at their visits a whole lot more refreshed because they hadn't had to endure the shame of walking by some of these places that treat them differently. And that's just the nature of it. So I'll throw in a few of these as we go along. So we treat patients in the outlying counties, Smith County. I was trying to think, Putnam County, which is Cookeville, Crossville. Again, these folks don't have a lot of TennCare providers in their area, so they come and see us. Now they're not having to drive an hour sometimes to our office, gas money back and forth both ways, a lot of good things. But right off the bat, what we ran into is, boy, the internet service in Portland, Tennessee is a whole lot different than downtown Nashville. And so that was a huge challenge early on, is what is the internet service? What are we going to do about people who don't have this thing that some of us all take for granted? What about technology issues? Okay, so I can teach my providers how to do this. And most of our patients have smartphones. It doesn't matter if they're homeless or what their living situation is, they have smartphones. So they have access to it, but they don't know how to use it. Right? They know how to use Facebook for sure. If I had a Facebook platform that I could deliver telehealth, I think I could help the whole world, right? Because everybody knows how to use Facebook. But when it came to using Zoom and some of the things that we were talking about doing, and then be able to farm them off into meeting rooms so that we could complete their therapy, that was another challenge altogether. So now we had the technology challenges. We had an inability to be there in person. So it's kind of like what we were doing just a few minutes ago with Brian and Carol and Rob Pack, because I'm the one that couldn't get logged on because I didn't have an access. Well, I have a phone and they're walking me through it. It's one thing to have that. What do you do when you don't have that? What do you do when you're not on the phone with somebody? And we can't do that. Guys, we have 1,200 patients. Now, how in the world do you overcome that? What about drug screening? How are we going to accomplish drug screening? Now, I want to talk about drug screening just a little bit. I see drug screening used all the time as the end all be all. It's going to be the thing that tells us how our patient's doing, no matter what. It's going to be what we make our sole decisions by. And I see many practices using it as a gotcha. So what in the world do you do with somebody who's trying their best and early on they keep having slips? Well, we give them a 3 strikes and you're out policy, right? They're out the door. Really? You just sent somebody who has had the guts to show up to your practice, who's struggling early on in recovery, as all of us do, as I did, even as a doctor who had every resource in the world, and you're sending them right back out to the street. So there's that mindset to overcome with drug screening, because sometimes some of our folks who oversee us, either from our administrative bodies, such as our governor and our legislature, or substance abuse and mental health services, put so much emphasis on a drug screen that you lose the fact that we actually have people making improvements. So I'd never use a drug screen as a gotcha. It's a tool to help people progress in their recovery. And sometimes it tells me that they need a higher level of care. Sometimes it needs to tell me that we need to up the intensity of other services. So that's the goal of drug screening. So it's a vitally important tool to us. But now, what do we do with it? Right? A patient can't come into the office, and I love the internet and I love the things technology can do, but I've never seen anybody have technology that could collect a urine sample over a Wi-Fi hotspot connection. I've never seen that. So we're going to actually have to do something around drug screening. And then those of you who know me know that I firmly believe this. I love medication for the treatment of opioid use disorder, for the treatment of nicotine addiction, for the things that we have medication that allows our patients to quell cravings. It doesn't cure them. It doesn't cure them. Okay. What helps people long-term in addiction is behavioral change, treating trauma. Those things happen over a long term. And when you look at this, and when I looked at this that weekend of the cancellation of the basketball tournament, this was my biggest fear, because I know, and I said this many times, and I'd like to take credit for coming up with it, but I didn't. The opposite of addiction is not recovery. The opposite of addiction is community and relationship. And now we're getting ready to take away community and relationship. And boy, my anxiety level was through the roof. I remember looking at my son-in-law, Sterling, and my son, Heath, going, guys, how are we going to overcome that one? And my son-in-law, Sterling, who's a genius, looked at me and said, Steve, actually on this Zoom app and the Zoom platform we're going to use, we can actually break people out into meeting rooms. And I was like, you got to be kidding me. And so now he's teaching me how to do it, and I learned how to do it really quickly. So I'm getting confidence that I can teach others. So what do we do with that therapy component? Because, guys, this is where the rubber meets the road. Medication's the bait. Medication's the thing that'll take them out of the acute addiction, the needle in the arm, right? All the behaviors. But now we're able to access therapy as well. And so I was very excited about that. So then we got into our solutions. Let me make sure I'm doing okay on time. I think I am. Hot dog. All right. So we got into our solutions. So we started looking at, how are we going to educate our patients? And so we had done this for some time before. In our practice here in Middle Tennessee, we've got a room right here behind me that we've set up that we do production in. And we're not the best actors in the world, but we do it. And we teach our patients things. All right. And so the idea I had right off the bat was that, okay, let's take these little short videos that Sterling and Heath can put together, and we can send them to our patients, because we're already using email and texting, right? We'd already been doing that with our patients for some time, particularly as we transitioned to e-prescribing. We 100% e-prescribe. So we had already done those things and we had them in place. And I said, what about making instructional videos and make them short, right? They can't be more than 2 minutes long. And instead of tackling it all at once, we have multiple little ones, okay? Because I learn things better in little bites of information. So we came up with our instructional videos. And we did it for laptops, we did it for tablets, we did it for home computers, we did it for everything we can think of. But the majority of our patients use what? All right, they use this. They use their smartphones. So we did videos from the point of clicking on the App Store and downloading the Zoom app all the way through. But we didn't do it in one big video. We did it in little 2-minute videos all the way through. So that was the first idea that we had, and it actually turned out to be a really good one, because we transitioned that idea into a lot of things that we started to do going forward in COVID once we got our patients used to the technology. And the big one around that one was education on COVID-19, because our patients were hearing all these things from the outside. It's dangerous. It's not dangerous. It's a hoax. It's not a hoax. It'll kill you. It won't kill you. Right? All of these things they're hearing. Masks are good. Masks are bad. You remember early on, we didn't have masks, right? Our Surgeon General says, well, masks only protect the person, they don't protect others. We didn't have any. So what do you do around masks? And which are the best masks? So the idea that we had from there was, hey, let's take these short videos that we've done and let's start doing them on things that they're hearing in the media. So what I did is I started searching internet hoaxes. Right. And I had things like people using blow dryers in their nose to heat up their mucous membrane so that would stop COVID, or using mouthwash or whatever it was. And then I would do a little short instructional video. And then we would farm all those out to our patients using the means that we were starting to use in telehealth. And guys, we actually still continue to do that one to this day. When the mask requirement came out, we did a thing with all the masks, right? Each one of the different ones, because our patients are scared. They're scared of what they're hearing, and they're losing their jobs. Most of my patients have jobs, but they were in the service industry. And we had patients that went from apartments. We had patients that went from homes that they had purchased, that they had mortgages on. And then I started seeing them in hotel rooms, and I started to see them in the backseat of their cars. And I never would have seen that without telehealth. And I'm going to talk about that in just a little bit. And I'm sorry, I'm getting off track a little. I get excited. All right. So we had the idea for instructional videos. Next, LTE on your phone, right? We had LTE service in places that we didn't have access to internet. And so we had to teach our patients about that. Most of them were familiar with that because they knew they could get on Facebook from this spot. And I said, look, if you've got an area you can get on Facebook for, okay, then that's where I need you to go, because your LTE service will be high enough there to get you on a Zoom app. Now, one of the things that the state of Tennessee did was allow us to not have to use video and audio together. Okay. So if I had you on and I had a bad connection, I could get you to turn your video off and I could just do audio. And that was really, really important, because in all honesty, I already know what my patients look like. Okay. Now, it does take away a little bit when you're looking for signs of oversedation or intoxication. I mean, that's a little different, but I need to be able to hear them more than anything. And so we were fortunate enough to be granted that early on. So that was one of the things we taught our patients. Another is, hey, where's the free internet out there? All right. So I found multiple apps that showed me where the nearest hotspot was. So we taught our patients how to download those apps, and they could actually click on them and figure out where the nearest free Wi-Fi was. And I became very grateful for certain institutions out there, and I'm going to promote them, not because of their food or their services, but because they have free Wi-Fi. And the first one is McDonald's. So I would tell my patients, do you have a McDonald's anywhere around you? Yes, I do, Dr. Loyd. Then drive there and sit in their parking lot. Dollar General, I am eternally grateful for Dollar General. Because Dollar General is my definition of a small town. If you have a Dollar General in your town, then you're a small town. And so all of these places had these Dollar General stores, and I could get my patients to drive to them so that they would have free internet. And just so grateful for those places. Starbucks, really, believe it or not, you do have some Starbucks in some smaller towns than you would think. And then the real key was that app that we discovered that was free. Again, we did an instructional video, showed them how to search it, showed them which one to pick. They downloaded it on their phone. Then they could click on that app and it would show them the nearest Wi-Fi hotspot. And then the remainder of the big solutions for us really came, from our leaders, from both our federal government and our state government. Governor Bill Lee and some of the things that he did early on with easing the requirements around telehealth and allowing us to see patients, even for a first-time visit using telehealth, opened up the world. It opened up access to treatment. We need that same access for methadone clinics. We need it, and we need it now. We don't need it tomorrow. We needed it yesterday. And yeah, there'll be some bad people out there that take advantage of it. I know it, but the majority of the people won't, and we will save lives of Tennesseans with this. So please, those of you that are on the line that are able to address this, we need it, and we need it really, really quickly, because we have Tennesseans dying and suffering because we don't have it right now. The DEA actually stepped up to the plate, and they got rid of red tape regulations that I thought would take 5 years to happen, and they happened literally overnight. And now we expanded this world of telehealth to where we could literally meet patients where they are. And I'm going to give you one sidebar because I'm so jacked up about this. But next week, I'm going to do a telehealth visit in Granger County with a young woman who is incarcerated. I'm going to see a patient behind bars. I'm going to give her access to treatment. I'm going to give her therapy all over a computer. And I'm so excited about that. All I needed was a judge and a sheriff, and I got both of them. So this has opened up the world for us. We can now take patients right out of the emergency department. We had 40,000 patients in the state of Tennessee in the year 2017, Tennessee Hospital Association data, that left the emergency department with a diagnosis of OUD, opioid use disorder. 40,000. May not have been their first diagnosis, but it was in the diagnosis list. None of them got a referral to treatment. Zero. We had 40,000 missed opportunities. We don't need ED docs that are addiction medicine trained. We ain't gonna be able to do that. We don't need to write protocols for them. What we need is access to telehealth in that ED, where we can treat them right there with an addiction medicine doc on the other end and get them access to outpatient treatment. Guys, we'll save lives doing that, and we'll save lives doing it in the criminal justice system too, utilizing this tool that we now have called telehealth. And for Representative Smith, you're the only one I can remember the name of on our screen. You can't put the genie back in the bottle. All right, the genie's out of the bottle. Let's use it now. It is never going to take the place of person-to-person interaction. It's not going to happen. That'll never happen. But it is a useful tool to reach hurting people where they are. All right, Carol, you're doing great. Next slide. All right, so what about drug testing? This is what so many people hang their hat on. Regulators love drug testing because they can come in with a pencil and put a check mark there that you did it and that it was abnormal, and then regulators love drug testing. But I had folks working for us that were really scared, right? We're going to have interaction with these folks. What are we going to do? And so the very first day one, we had put in everything that I had learned from following the people that I was following from the CDC, from really early on. Governor DeWine in Ohio was one of my sources, and his wonderful director of the Department of Health, who actually resigned right in the middle of pandemic, I think, from the pressure, but she did a great job. And so we had everything social distance in our office. We went to 100% telehealth, but we had some patients that didn't have email, didn't have text, that showed up at our office. So we had our offices socially distanced. We wore masks from day one. We had cleaner everywhere. We had computers set up in our rooms so that our docs could actually see patients in the room, but not be in the room with them and expose themselves. And then for drug testing, that was our big thing. How are we going to keep our lab personnel safe? Because they're scared as well. So what we did was one of the things that we really loved. And Mary Shelton, I know you're on the line, and this was huge for us. Oral swabs. Oral swabs are wonderful. We could actually have the oral swab container there with a set of instructions right next to it on how to take it out, swab your own mouth, right? Because we know all we need is saliva, and it's really hard to bring somebody else's saliva in. I'm sure somebody could do it, but that's a tough one. So how to collect a sample, stick it back down in that tube, lay it in our holder, and we never have to touch you. The problem that we had with that one was that our MCOs, our 3 MCOs, did not reimburse for drug screening that was an oral swab. And so we need that one removed at some point, because that's still an issue. The thing is that there's no difference between oral swabbing and the regular urine drug screening. It's the same code on an insurance form. So the only way that they'll know is that we tell them. I would like to be upfront and honest and tell them what we're doing and why we're doing it. So the oral swab was a godsend right from the first. And we were able to do that for patients coming in the office. But the other thing that we were able to do utilizing telehealth was tell our patients, hey, when you're out and about, sometime in the next 2 weeks, stop by the office. And so we had all this set up so they could just come in. We didn't have to have appointments for them. They went ahead and dropped the sample right there using oral swabs, put it back. It was all no touch, all completely no contact. Next thing, what about urine drug screening? Well, we figured that was going to be the next best thing, although it would have to be a little bit more patient contact. And so we set up basically the same thing for urine drug testing as we did oral swab. We did have a little bit more with that one in patient contact in a way we couldn't figure out how to do this. And they're catching their own urine sample, but then they're putting it back in the bottle. And then, we have a warm handoff for that. So we utilize gloves. Wasn't much of a difference, but oral swabs were really the thing that saved us there. But we do need to work on removing that barrier for it being reimbursed. Just reimburse it the same thing as you do urine drug screening. You don't need more money. It doesn't cost any more. And it's very, very effective. Next slide. So what were the unexpected benefits? Well, hold on. Before I go to that, let's go to therapy real quick. Um, pardon me. See where I'm time was. So the therapy aspect of it was really, really interesting. We had this platform, and we use Zoom Health, but there's a lot of other platforms out there that would do the same thing. So basically, and Carol, I'm going to use you. I've got Carol Myers as my patient, and I'm seeing her on Zoom just like I'm doing right now. And so I can do all the things that I need to do. I can get my history. I can find out how Carol's doing. What are the things going on in her life? What are her stressors? What are things that she needs my help with from a medication standpoint? How's she doing? Does she feel over sedated? Is it wearing off? How's she doing with cravings? All things very amenable to what we're doing right now. But I know what's going to help Carol long term is behavioral therapy. And I'm not a behavioral therapist as much as I would like to be. I'm just not. And so how do we manage this? Well, at that point, I look at Carol and I say, Carol, I find out who her individual therapist is, or if she's participating in groups, because we have both of those options. We have group therapy with no more than 6 or 7, and then individual therapy, one lasts longer than the other. And then I figure out which one she is. And I go down to my little thing down here at the bottom where I can invite other folks in. I get my therapist and I've got my patient on the screen. So we're actually sitting here, all 3 of us talking, and I can look over at my therapist. And my favorite therapist is Lori. So I'll use Lori. I said, Lori, I've got Carol here today, and Carol's having some issues in her relationship. Her husband has been verbally abusive over the past few weeks. They're feeling financial stress from COVID-19. And she's really struggling around this. From a medication standpoint, she's doing really well. So now I've given my therapist what's going on from the medical side. She knows what I'm doing. She knows what dose of medication my patient's on. She knows how she's doing from a drug screening aspect. And she knows the things that I've uncovered in the visit. And now I've got a list of rooms I've created. The most I ever created in one day was 10. So I had 10 rooms up over here, and I put Lori and I put Carol in that room, and then they go off and do what they need to do. And I know the visit is over as I track it on my left when I see them both leave the room. Now that one was a little bit more of a challenge, but we utilized things from lessons learned early on. The best way to teach our patients how to do that, short video. Okay, so we utilize short videos to teach our patients how to do that. We still had patients that would come into the office. And so everything that I've taught you guys about telehealth so far, we also put down on paper. All right. So we had patients that couldn't utilize any of this that wanted to come into the office and do telehealth from the office. And we did a fair amount of that. Probably about 5 to 7% of our patients did that. So we had the computers all set up for them. And so we listed this other step by step how you did it. And we gave them access to the videos that we had sent to our other patients through electronic means on that computer so they could watch it and learn how to do it themselves. So the therapy thing turned out to be a really, really good thing. Although in all honesty, I can't wait till we can get back together, because there's something about that meaningful face-to-face human interaction that is so critical to people who are suffering from addictive disease. So what I learned some things from this I wasn't expecting to learn. I had no idea that I was getting ready to step into my patients' lives. Carol comes to see me for a doctor's visit. We have a nice office. Carol's going to come in and sit down in a really nice chair. I'm going to come in doctorial, but Carol, I'm not going to have a stethoscope and white coat on. That's not in my nature. But I'm going to come in and sit down across from Carol, and we're going to have a doctor-patient interaction for 10 or 15 minutes. And then Carol is going to go about her life with therapy, drug testing, all that other stuff outside of me, her visit to the pharmacist, the whole deal. Okay. That's a finite amount of time. My data that I collect from that visit is really going to be based on how good an actor Carol Myers is. How good a face can she put on for 15 minutes? Okay. Now with telehealth, I'm sitting in your living room. I'm sitting on your back porch. And unfortunately, I'm sitting in your hotel room, the back seat of your car, or I'm sitting with you on a sidewalk. And I'm going to tell a story on myself here that I'm embarrassed by because of my lack of insight in the world I live in. I had a patient, we'll call him Brian. I had a patient, Brian, who had a really good job. When I got him, he was addicted to heroin. We got him off of that. He was on Suboxone. He was progressing through the program and doing really well. And he got a job at B&A, our airport here in Nashville. And he was part of the crew that takes care of your environment, heating and cooling. And he got a promotion. And he was over all of the thermostat settings around B&A. And B&A is a busy, big airport. And he made really good money. And he and his wife had a home. They had 2 children. And so we got into the pandemic and we got through the last part of March and the first part of April. And as you all know, in Tennessee, then we were pretty much locked down. And we got into early May. And actually, it was late April. We got into late April and I did a visit with Brian, a telehealth visit. And he's in his car. And I saw his kids in the back seat on computers. And I said, "Hey, Brian, are you living in your car?" Like that. And I laughed. And he said, "Yeah, Dr. Loyd," he said, "I am." He said, "I lost my job." He said, "Nobody's flying. They laid off most everybody we have." And he said, "I got evicted after I missed the second month payment." And it didn't matter what was going on at the federal government level. It says we're going to put a moratorium on evictions. It didn't matter. Our patients, for the most part, aren't renting from places like that. They're renting from places that'll rent to them without a deposit, without a credit history. Folks in charge have got to know that. It's a different world than we live in. My kids, the worst day they ever had is the TiVo in their bedroom wasn't working or the cable was out. These kids were laying in the back seat of that car on their computers in school. I was at a loss for words. I apologized to him, and I still see Brian. He's got his job back, by the way, and he's not living in his car anymore. But I started to see patients like that, and I started to pay really close attention to what was going on in backgrounds. I started looking at people's houses. I started looking and seeing what they had, and all of a sudden, this world is opened up for me, and now I'm really in their lives. You can't put on a picture for me in there in 15 minutes when you're sitting on a street corner. And I got a little bit nosy because you could be seeing me on a street corner because you're out and about in your daily life. But now I had the courage. "Hey, Brian, I know you're outside right now and I can see you're outdoors. Are you just out and about, or is there anything else that we need to talk about? Because here's what the deal is. I have access to help. We partner with folks that can help you with housing. We partner with folks that can help you with food. I volunteered organizations myself here in Mount Juliet, Tennessee, that we can help you with groceries. But I don't know when you put on a face and come in my office and look good for 15 minutes. And now I do. And guys, I loved it. My heart's been broken. I went home at night crying, but we've helped a lot of people. And we got to be able to continue to do that. I don't give a crap what your politics are, which side of the aisle you're on. I don't care. I'm a one issue guy. This is my issue. Okay. We need folks on both sides of the aisle to help us in this endeavor, because there'll be some that take advantage of the system, guarantee it. There'll be some that divert their medicine, but others will be like that lady that you all see on your screen right now. And I have her permission to do this written. I've got a ton of lawyers that have checked this out, so I'm okay. But that's my friend and patient, Nicole Godinez. Nicole, that's only one of her twins. She had 2. She had 2 of them back really early on in the pandemic in March, right after we went to telehealth. And this is horrible, and you're all going to think I'm a bad person, but I did a telehealth visit while she was still in the labor and delivery room. She had an appointment that week, and it just so happened that the best time for her to get in touch with me, because she was panicking, was then. So I did it then, and Nicole admits she didn't look her best there, but I think she looks beautiful. And she's worried about coming into the office because now she's got 2 babies. She doesn't know what their immune system is. She doesn't know what the effect of coronavirus is on newborns. She's scared to death of getting it herself and not being able to care for her two new babies. And I said, well, Nicole, guess what? We can do it just like this. I'm coming to you today right like this. She had her phone. I had her husband take this picture and send it to me because I wanted to tell this story. This is a story you didn't think about. Because when you go in the hospital and you tell the nursing staff that you're on Suboxone, a lot of times they're going to look at you differently and start treating you differently. She didn't have to do that. She could meet me there. I'm her doctor. I did a telehealth visit. We did an appointment for her. She never even had to come to the office, and she sent her husband to the pharmacy to pick up her medication. Nicole, by the way, is still doing well. She's who I use whenever we do any of our media stuff because she wants to tell her story. And so sometimes, Representative Smith, when you're looking at stuff, and I know there's people on the other end of it. There really is, and these people's lives are changed by that. Things that you guys have done in the legislature with access to Narcan. I've had people come in my office with a little pouch, and on the outside of the pouch was the Tennessee seal, the TN, and they said, Dr. Loyd, somebody had one of these, and they reversed me with Narcan. So that came out of programs that you guys made and put in place, and the Tennessee Department of Mental Health and Substance Abuse Services put out in the field, and Narcan was available to save that mommy or daddy. They matter. The things that Mary Shelton and the folks at TennCare do every day in relaxing some of this stuff allows us to access people like Nicole Godnez and change their lives. And Nicole's going to be a better mother because she's got help and she's had access to care, and she didn't have to come into the office. And I love telling those stories because those are my anecdotes to my Brooke Sargent stories, who died because she didn't have access to treatment in a state that didn't have Medicaid providers to treat her for her opioid use disorder. That is a needless death. Those are the ones we can prevent. And I'm going to close with the last thing I certainly was not counting on during COVID-19, but you'll see some data to your right, and that's 2020 patient count. And here at Cedar Recovery, our patient count is actually up almost 30%. I put greater than 10% on there. Our practice has grown by almost 30% from this time last year because we had access to telehealth, and we also had a state legislature that crafted a law last year that said you can't charge TennCare patients cash for benefits that are covered by their TennCare, regardless of whether or not you accept TennCare. So we started getting those patients, instead of paying $300 a month for medication, they could take that $300 and spend it on their families and spend it on their children, and their TennCare benefits would cover the cost of us and cover the cost of their medication. And so we saw our patient count grow by about almost 30% last year. But here's the big one. Our no-show rate is less than 10%. I've had multiple days in my practice where my show rate was 100%. That's unheard of in this field. These are people that are engaging in the treatment process. These are people that are not accessing care through emergency departments, which is ungodly expensive and a drain on our state Medicaid agency. Yesterday, I saw 34 patients. I only had 32 scheduled. I saw 2 work-ins. So I was above 100% yesterday. It has given people access to care. We have taken stigma away from walking through the front doors of our clinic that still exist. People know what we do, and we've taken that out of the ball game. So I want to end on a bright note. More people getting treatment that's evidence-based, that's paid for through the benefits, through their state agencies, and they're showing up for it. And so Carol, I have no idea. When you came to me and asked me to do this, I had never put together a talk like this. I hope it's what you were after, but I will tell you for sure, it's what's going on in the state of Tennessee right now. And for Mary, I look up and see Mary in the corner. Thank you. Thank you for what you guys do for our patients.
Well, Dr. Loyd, you exceeded my expectations. We wanted folks to have an understanding of the problem that we're dealing with and how telehealth is part of the answer. So thank you so much. And then you did exactly what the research says is stories are what's important. Data makes us credible, stories make us memorable. So thank you. I hope that you're able to stay with us. I understand if you're not, because we will discuss some of what you talked about on our panel discussion. So without ado, I'm going to move to that.